Good morning, this is Giulio Rasperini, and this is a patient with a severe periodontal disease, as you can see, and now after non-surgical treatment, we can approach this upper right side of the mouth. You see, the non-surgical was very effective. As you can see, the periodontal pockets is severely reduced. And but we still have some pockets of 5 millimeters and more. So the patient will need surgery because we need to finalize the complete closure of this intrabony defect to be maintained over the time. So the best approach in this side, we don't need to improve the aesthetic. The aesthetic is acceptable according to the patient. So we just need to have access to the intrabony component and to remove the granulation tissue inside. So this will be a very intracircular incision, beveled, as you can see. So in this way, we can just elevate our flap, but we have a different defect also here. So we can do an incision at the base of the papilla, touching the bone down there, and then continue distal on the tooth number 5. So it's a very small incision that involves the distal part of the canine, all the tooth number 4, and the mesial part of the tooth number 5. So with a micro elevator that is part of the kit, of the surgical kit from Ufredi that I designed, you can see this instrument is to elevate the papilla, and I use also as elevator itself. We can elevate in a minimally invasive way. That means we don't cross the mucogingival line. So we will be very gently reflecting the buccal aspect of the flap without reflecting the interproximal tissue. So the papilla that is in the interproximal aspect is not touched. We just clean the intrabony defect below this papilla that remains in place. So we'll continue to have the vascular supply, the blood supply from apical from the periodontal ligament. So the incision is basically finished, and now we can, with our mini curette, just protect the flap with the elevator and just remove the granulation tissue from the intrabony component. You see, this is a very narrow defect. So with our small curette, we remove this soft tissue that is into the intrabony component after the healing of the non-surgical phase, and is not anymore granulation tissue. This is just scar tissue. It's a kind of soft tissue that doesn't allow the complete regeneration of the deep part of the intrabony defect. But so we will need to remove it, but it's not full of bacteria, it's not inflamed, there is no calculus. All these things has been taken care of during the non-surgical phase. That's why we have a nice soft tissue with a good quality, not bleeding on probing. Now with our mini curette, this is the for the mesial surface, so it's the 11-12. We can remove the granulation tissue, as you can see, and scale the root surface gently. Yeah, it's always amazing how much tissue comes out from these little defects, and I'm always impressed about that. And this is the curette 1314. So this is the curette 1314 that should be used for the distal aspect of the surfaces of the premolars and molars. And in In this case, it's for the mesial, but as you can see, we are using in a reverse way, and we use the tip as an excavator to remove the granulation tissue into the intrabony component. And it's very important to keep clean, but you see it's a really minimally invasive approach. We are now just elevating a little bit more, but without passing the mucogingival line. It is very important, don't cross the mucogingival line, so you will have a very stable wound, as described by Arel already in 1995, when described the microsurgical approach, and also in other description of this technique. And you can see you can use again your curette, and now we are changing the setting. Okay, and yeah, we can. You see the quality of the soft tissue into the intrabony component is very solid, has a good tone, the tissue, and is not as bleeding tissue with bacteria inside. It's not inflamed, there is not inflammation anymore, and we left also enough period of time for the healing to take place. This is very important according to our philosophy of treatment, to give the proper time of healing to the tissue, because if you are in a hurry, you will never have good tissue to work with, and your procedure will be less good quality and more risky for shrinkage of the tissue and the incidence of the flap. Now, the distal aspect, we are already pretty much satisfied. We go a little bit more with our curette, and we need to work also in the mesial aspect a little bit more. We finalize here. You see, this is 11, 12. This is the mesial aspect of the tooth number 5. And now this is the mesial aspect of the tooth number 4. Again, with a 11, 12 curette. Now we take the curette 7, 8. And we again approach the tissue. We change already within the 13, 14 curette, mini curette. We basically don't use anymore the regular curettes, especially for this type of sites, but we don't have in the office. Now, basically, we only work with mini curettes, are much more precise, less damage to the soft tissue, that cause less shrinkage of the tissue, better aesthetics, better papilla preservation, and more precise with the tissue that you really want to remove. And we are working on the base of our papilla, and this is again the 11-12. As you can see, we are already visualizing properly our intrabony component. And as you can see properly your intrabony component, and you're sure that there are no more soft tissue. You see, it's how much tissue you can get out from these intrabony defects. But as I told you, there is not inflamed tissue anymore. This has been taken care of during the non-surgical phase. So there is no more bleeding on probing, and the tissue is under control and with a good tone. So we now are using excavator as you can see, this is an excavator. And with the excavator, we are removing all the soft tissue inside. And removing all the soft tissue inside, also from the edge of the intrabony component. You see, it's usually very well attached in this area, so with a sharp curette, you can cut it away. You see, the intrabony component is like 4.5 millimeters in this area, 4.5 millimeters, but it's a nice 3-wall defect, contained type of defect, and also distally, we see if we wash, we have like a 3 millimeter intrabony component. So the large healing occur thanks to the non-surgical, and then to finalize the regeneration, we use the periodontal regeneration surgical approach. But this is the right way to approach this type of disease. Not like in one step, but in 2 steps before the non-surgical, moving the patient to be compliant, to clean properly, to quit smoking, to control the diabetes, to check the trauma from occlusion of the teeth, stabilizing the occlusion, and at the end, the patient can be treated surgically, only after all this. Typically, my patients are treated surgically not before than 6-8 months after non-surgical treatment. So we go with the ultrasonic instruments to be sure that there is no biofilm on the root surface. And now we can place the EDTA in a way that we can remove the smear layer from the root surface. And while we wait for the 2 minutes, we can already start from the mesial aspect to prepare the suture. As I published in 1999 in the surgical technique, when we apply growth factors to periodontal regeneration, actually that was the first surgical technique published to have growth factors like a gel, non-contained, non-membrane, let's say non-membrane. It was published in 1999 on the International Journal of Periodontal Restorative Dentistry. We always prefer to perform the suture in advance. In this case, we don't need a complicated suture like Laurel Gotlow and others. Is enough an easy suture that enter in the center of the papilla buccal and exit in the center of the papilla palatal. Now the suture is ready. We just open a little bit the flap, and we can add, wash away the EDTA that we placed before, of course. And now we can add our biomaterial, which is usually a gel of growth factor, in this case EMD, amelogenin, pre-mixed with deproteinized bovine bone. Okay, we elevate a little bit our flap. The defect is clean. There is a little bit of clot already forming inside, you see, and we can compact inside, but gently, not in a too aggressive way, our biomaterial. And the aim of the proteinized bovine bone is to create a scaffold to stabilize the clot, and the aim of the growth factor is to induce the periodontal regeneration, as we know by the studies from the literature. We can remove the material that exceeds, and now we can already stabilize our first suture on the mesial aspect. And this is a very simple suture, and we just can make our knot. And that's it. And we can wash away the biomaterial that exceed. If you place a membrane, you cannot do that. And if you place a membrane, you have to open a much bigger flap because the membrane should overlap the defect. In this case, with the growth factor and a little bit of scaffold material, you can approach the defect with a minimally invasive approach. And this is the single flap approach again. And we can cut the suture now. Here we go. And now we can approach the distal defect. Again, we prepare the suture in advance. And after that, here we go, in the center of the papilla, a little bit apical. We don't want to be too close to the incision, and we exit palatal also in the center of our papilla. And now with the back of the needle, we go into the interdental space, and now we are ready to add our biomaterial again. So we open gently the flap, and now we can open gently our flap and add a little bit more biomaterial also in this distal area. Now we can pack our biomaterial inside. It's the same as before. EMD, amelogenin with the proteinized bovine bone, but again, the key is the clot. It's the red part that you see into the defect that will regenerate the bone. Into there are all the information for the cells to become new cells of the periodontal ligament, induced by the EMD and protected as a scaffold, stabilized by our flap, our surgical approach, but also by the scaffold, the biomaterial itself. Now we can close the suture. So you see we avoid the verticals, and the flap is very stable. It's like to open and close the laptop of your computer. You see the flap closes exactly where the incision has been made. You don't need to corral in advance. You don't need to release the periosteum. So it's really minimally invasive and very stable. At the end, must be very stable. This is going to be the key. The teeth need to be stable as well. In this case, are stable. If they are not completely stable, check again the occlusion, or you can also splint them just before the surgery in case there is a residual mobility of the teeth. Now we put the patient under antibiotics for 5 days, amoxicillin, and we will give an anti-inflammatory, and they can take more in case they need. But usually they don't need anti-inflammatory for this procedure. That is really painless. And of course they cannot brush, so they will rinse with chlorhexidine solution, and we will see the patient after 8 days again. And so here we go. It's a very nice stable wound, and we will check again the patient. We will clean for a week, and we will check the patient again with radiography, etc. 6 months later.